Okay, let's get right into it. We're going to tackle a topic today that is, and I mean this, absolutely critical for every single anesthesia. It's a huge subject for your final exams, and that's the perioperative management of supraventricular tachyarrhythmias, or SVTs. Getting this right is just fundamental to keeping our patients safe. And this quote, well, it really sets the stage, doesn't it? We're not just talking about a fast number on the monitor here. We're talking about preventing some really serious complications, things like stroke, myocardial infarction, and heart failure. The stakes are just incredibly high. So, just how common is this problem? Well, this number, 6%, really puts it into perspective. That's the chances of a persistent SVT popping up after non-cardiac surgery. It happens all the time, and it's a challenge we all have to be ready for. So here's our game plan. We'll start with why SVTs are such a big deal in our world, then we'll get into how to classify them, how to diagnose them, and then we'll walk through the all-important management algorithm. And to wrap it all up, we'll do some exam-style questions to make sure all this knowledge really sticks. Okay, let's jump into our first section, the perioperative challenge. What is it about the surgical environment that makes it such a hotbed for these arrhythmias? So first things first, what are we actually talking about here? An SVT is basically a fast heart rhythm that needs tissue above the ventricles to get started and to keep going. So that's either in the atria or in the AV node. The name really says it all. The problem starts supra, or above the ventricles. Now, what's so interesting about this list is that it basically reads like a daily to-do list for an anesthetist, right? Pain, low volume, electrolyte shifts, using inotropes. The whole perioperative environment is just this perfect storm of triggers that can tip a vulnerable patient right into an SVT. All right, moving on, let's talk classification. And really, the most important first step is super simple. Is the rhythm regular or is it irregular? Because that single distinction points you directly to what's going wrong with the heart's electrical wiring. And this slide just illustrates that difference perfectly. So on the left, you've got a regular SVT like AVNRT. Think of that as a single, predictable short circuit, just looping around and around inside the AV node. But then on the right, you have atrial fibrillation, and that is pure electrical chaos, hundreds of random wavelets firing off, which causes a totally irregular response from the ventricles. Okay, section 3. So we know what they are. Now, how do we actually figure out which one it is, in the heat of the moment? This is all about taking the clues from your patient, from the monitor, and getting to a solid diagnosis. When that alarm goes off and you see a fast rhythm on the monitor, this is your first and most critical question. Seriously, forget everything else for a second and just look at the RR interval. Are those QRS complexes marching along in perfect time, or are they completely all over the place? This one observation is your main branching point for everything that comes next. And here's a classic example of a regular SVT, atrial flutter. So what's happening here is the atria are firing away at around 300 beats per minute, creating that famous sawtooth pattern. Now, the AV node, it acts like a bouncer at a club. It just can't let that many signals through. So it filters them, usually in a 2-to-1 block, letting every second beat through. And what's the result? A perfectly regular ventricular rate of 150. Now, look at the difference here. This is atrial fibrillation. The baseline is just chaotic, you can't see any real P waves, and the RR interval is completely random. This irregularly irregular pattern is the absolute #1 hallmark of AF. Which brings us right to the heart of this whole explainer, the management algorithm. This is where we go from theory to practice, where you have to act and act decisively to protect your patient. So imagine this. The rate on the monitor suddenly jumps to 190. The alarm is screaming. Before you even think about what rhythm it is or which drug you're going to grab, what is the single most important assessment you need to make right now? The answer is right here. It's all about one question. Is the patient stable or unstable? Do they have any of these adverse features? Is there blood pressure in the gutter? Are there new ST changes on the ECGs suggesting ischemia? This one question dictates your very next move and tells you exactly how much time you have or don't have. And this algorithm lays it all out beautifully. Just follow the path from the top. The first question is always adverse features. If the answer is yes, your patient is unstable, the path is direct and it is urgent. Synchronized DC cardioversion. End of story. But if the answer is no, the patient is stable. That buys you time. So you move down the algorithm, you get a 12-lead ECG, and then you make your next decision based on whether the QRS is narrow or broad, regular or irregular. And that leads you to the right drug. All right, let's wrap up with our final section and really cement this knowledge. We'll run through a few rapid-fire exam-style questions that cover the most important must-know concepts. First question, your patient is stable, no adverse signs. On the monitor, you see a regular, narrow complex tachycardia ticking along at 180 beats per minute. What is your go-to first-line drug? The answer, of course, is adenosine. And it's the perfect choice because it does two jobs at once. It's both diagnostic and therapeutic. By temporarily blocking the AV node, it'll just stop any reentrant rhythms that depend on that node, like AVNRT. But if the rhythm's actually atrial flutter, it won't stop it, but it will slow the ventricular rate way down, enough to unmask those classic flutter waves. And because it has an ultra-short half-life, it's incredibly safe to use in a monitored setting. Okay, next question. Let's switch gears to the most common arrhythmia we see. You have a stable patient who develops new onset AF during a case. What's your main therapeutic goal here? Are you going for rhythm control or rate control? In this acute perioperative setting, your goal is almost always rate control. I mean, think about it. All those triggers are still there, so trying for rhythm control is often a losing battle. Instead, we just focus on slowing that ventricular rate down. A slower rate gives the ventricles more time to fill, which boosts stroke volume and cardiac output, all while reducing how hard the heart has to work. All right, last one, and this is a massive safety point that you absolutely have to know. Why must you never, ever give standard AV nodal blocking drugs to a patient who has atrial fibrillation and an underlying WPW syndrome? Here's the critical danger. In WPW, there's this extra electrical highway, an accessory pathway that bypasses the normal AV node. So if you give a drug that blocks the normal route, you're essentially forcing all of those chaotic atrial impulses down this unprotected superhighway. This can cause a ventricular rate of over 300, which will very quickly degenerate into ventricular fibrillation and cardiac arrest. It is a potentially lethal mistake. Now, all the information we've gone through today comes from this fantastic 2014 review article. You know, understanding these pathways and algorithms, it's not just about passing an exam. It's about being prepared to make the right call quickly and confidently when your patient needs you most. Thanks for joining me.